Ready.
Okay, now we're going to look at a treatment protocol for the hip joint. If the patient has knee pain, I suggest maybe leave it alone, treat the hip or focus on the hip joint. Exactly the same if someone has chronic lower back pain or even acute lower back pain, then rather than just treating the lower back, you might find, especially if they're not progressing with treatments, so maybe leave it alone and focus around the hip joint. In the earlier video, if you're looking at, I said with this patient, there's a potential for a labral tear, an acetabular labral tear, with maybe a slight cam lesion. I don't know because I don't have eyes that has MRI, so I can't scan and see exactly what's going on. But in terms of treatment, this movement, if I was to go into full flexion, would irritate. If I go into full flexion with adduction, that would irritate. So we almost want to work within a boundary without irritating the joint. Every time I go in and irritate, the patient's is going to be a reaction. And so I don't really want to stimulate the pain sensors within that hip joint. So the first of the movements I tend to do, I tend to just encourage external rotation because all the movement are done passively. And then I can, if I want to, encourage movements where I'm just slowly encouraging internal rotation. But I have to be a little careful in this one because there's a potential to catch. I could back off 90 and just mobilize the hip less than 90 degrees. I can lower the leg down and encourage mobilizations of internal rotation, and I can encourage mobilizations of external rotation as I go through all this. Bringing the leg back up, a circumduction movement within the tolerance of discomfort, so I know I'm not going to irritate in this angle, so I would come in and circle one way, circle the other way. I don't have any set numbers or time of how long I would do this for. I bring the leg around. You can, if you want to, almost like do a figure of 8 movements. Think about the hip as an engine, and then the synovial fluid as an oil. So by trying to do these mobilizations, and then we can come in, and then we can just increase. So we just secrete in the synovium, which might help the hip position. From here, I will cradle and just mobilize the hip, but I'll start to add in a bit of abduction. I might be tempted to stabilize and lean in and do an MET from here. Your knee, my chest, push me away. So the patient will push for about 10 seconds, activating the hip extensors. After 10 seconds, relax, take a breath, and as I breathe out, just add in a bit more stabilize. We can just stretch through, we can change angles. As long as we don't go too far forward, you might find that it actually helps open the hip joint rather than cause compression pain coming across you. A couple of traction techniques I use. I tend to sit on the foot, hand through and over my forearm, hand on top of the mid-thigh, and apply just a slow bit of traction. Be careful on pressure to the calf. So slowly just apply some traction. Again, you can sustain the traction, so you can hold it there, and you can ease off, and you can just mobilize whilst the hip is in traction, and that works very well. Very good for pain relieving. Also, because you move a hip, you move a pelvis. Because you move a pelvis, you move a lumbar. So it actually applies traction to the lumbar spine, especially to L5-S1. And also it gaps the SI joint a little bit. So you might find it can help these little techniques. The other way of tractioning, the longer lever technique, I normally would hold that knee in that position, or the patient would hold it. Hold the leg. Internal rotation traction applies to the iliofemoral joint, but actually internal rotation locks the iliofemoral ligament, and it actually can traction the SI joint. If I turn the leg out, then it can mobilize the actual hip joint, okay, which is the iliofemoral joint. Sometimes I might push in for 10 seconds, cause a compression as long as it doesn't cause any pain, ease off and apply some more traction. Sometimes a little bit of mobilization at the end works okay. From there, turn the leg in. Be careful on manipulating the talocrural joint here. So you almost have a cradle roll and just apply traction backwards. Sometimes you just have a little traction technique if you want to. One more on a traction. This is a lateral glide. So from this 90 position, arms low, and then literally a bit of glide coming across here. So a little bit of traction. If it is irritating the adductors, a pillow between your arms and them, and apply a little bit of sustained traction there. Ease off, and traction across from there. Okay, good. Can you have a lie using the face like this, if that's okay? Unless you want the pillow. Maybe the foot. Let's use a pillow. Maybe head to one side, arms hanging. So it's a left hip I want to work on, excuse me doing this. Bending my knee to 90 degrees. Now, using like a relaxed wrist on your forearm here, rather than bend in, so this is a sort of position, and then I'm literally just going to internally rotate, externally rotate. So that's external rotation of the hip. This is internal rotation. So I'm just literally going to lock into the tissues and just slowly mobilize into external rotation. Okay, a nice way of treating the soft tissues. Depends what your goal is. If I'm externally rotating, the deep rotators, the piriformis, the the obturator, and the quadratus femoris are naturally being shortened in this phase. So if I want to lengthen them, I can lock in and then internally rotate. So I can use my knuckle, if you like, or use my fingers, and I can just slowly mobilize through the tissues here. Again, I can work across the upper glute, as in the glute medius, glute minimus, on that side. If it is a restriction, let's say there's an internal rotation restriction here, I could say to the patient, pull your leg across please, for 10, for 9, for 8, using resistance on my fingers. After 10 seconds, relax, take a breath. And as she breathes out, stabilize the sacrum, and then slowly internally rotate. So we're just encouraging lengthening of the deep rotators. And that works very well. And then again, you can come back to locking the tissues, and then mobilizing, going across, working through that. There's nothing wrong with the hamstrings. You can almost like lock into the hamstrings and just lengthen through some of the hamstrings, and that works very well. You can come in this way, working through. And you can also work to lock and lower the lower leg. So you can almost like fixate the tissues and just change angles. So I think all this, because the hamstrings are particularly tight, because the glute is not working very well, then it's a nice way of loosening. On this side, a couple more things we can do. We can hand underneath the knee. If you want to encourage the nominate to go forward by using the glute, we can say to the patient, so I can feel hamstring and glute. Can you squeeze your glute and lift your leg? Okay, and relax, so squeeze your glute and lift your leg. So then as they do that movement, off you go. So I can mobilize, so I can activate the glute, which encourages extension. It will assist in lengthening the psoas. And then I can also mobilize the hip anterior. If you're struggling with the hamstrings kicking in too much, potentially by bending the knee, okay, now activate the glute, you might find it easier, so the hamstrings are not working so much when they lift the leg. If the rec fem is particularly tight on that one, change the angle to around maybe 45 degrees, and again squeeze, and then they can lift as they do these movements. Okay, so this is a few little ideas of one way of treating the hip. If you find the lower back is too lordotic, then maybe one pillow, two pillows, just to flatten this out, because you might find the more extension of the hip, the more L5, L1 compresses the facet. So just be a little bit careful when you're doing those techniques. Okay.